Hello and welcome to another episode of Health Matters. I am your coach, Dr. Michael Chillemi, and on this episode, what we're going to talk about is the shoulder. We're going to understand everything about the shoulder. We're going to take a deep dive into the most complex joint in the human body, whether you're dealing with pain, stiffness, mobility, arthritis, rotator cuff tears. When we're done with this episode, you're going to understand everything you need to know. Shoulder problems affect millions and millions of people globally, yet it is usually the most misunderstood joint in the body today. So, with that, let's try to help you understand the shoulder a little bit better. So, why is the shoulder so unique? The shoulder offers the greatest range of motion of any joint in the body, enabling you to raise your arm, put it in various positions. And because it's so mobile, it makes it very susceptible to instability, injuries from repetitive strain, dislocations, degenerative conditions. So, with that, let's get into understanding the anatomy of the shoulder. So, the shoulder is a ball and socket joint, right? So, the ball and socket joint is designed for extraordinary ranges of motion. Unlike other joints, it prioritizes mobility over stability, leaving it very vulnerable to injuries like wear and tear, structural defects, and degeneration. So, structurally, the shoulder is made up of three key bones: the humerus, which is your upper arm bone, the scapula, which is your shoulder blade, and your clavicle, which is your collarbone. These bones are supported by interconnected systems of tissues. The first system is muscles. Inside the muscles, which mainly makes up of the rotator cuff, plays a critical role in shoulder stability and movement. It comprises of four scapulohumeral muscles. First is subscapularis, supraspinatus, infraspinatus, and teres minor. So that's subscapularis, supraspinatus, infraspinatus, and teres minor. These are all vital for movement, strength, and stability of the shoulder. Other important muscles, such as the deltoid and pec major, provide additional strength and mobility. We'll call them secondary muscles. Next, you have tendons. Tendons attach the muscles to the bones. The rotator cuff tendons are important for smooth shoulder motion, but they are prone to inflammation, tears, and damage. The tendons of these muscles integrate closely with the shoulder joint capsule and serve to centralize the humeral head, right? Keeping it in place, preventing excessive upward displacement during arm movements like abduction. Abduction means you're moving the arm away from the body. All right, ligaments. Ligaments connect bones to each other and provide essential stability to the shoulder. Then you have cartilage, the labrum. So your ball and socket, right? So the inside the socket is the labrum. It's a ring of cartilage in the shoulder socket, acts as a cushion and facilitates smooth movement. So you have muscles, ligaments, and tendons, right? Okay. Additionally, the shoulder's movement depends on the complex interplay of multiple joints. The glenohumeral joint, which is the ball and socket between the humerus and the scapula. The acromioclavicular joint, which is the joint between the clavicle and the scapula. It's located on the top of the shoulder. The sternoclavicular joint, which is the joint between the sternum and the clavicle, connecting the shoulder to the chest. So the sternoclavicular joint is here. The AC joint is approximately here, right? So it's by combining flexibility with highly complex anatomical structures, the shoulder achieves unparalleled versatility. But its cost is its vulnerability to injuries and degenerative issues. Understanding the anatomy allows for better intervention and treatment in cases of shoulder problems. So let's get into chapter 2, which is going to be the pathogenesis of shoulder impingement. So pathogenesis means how it starts. Fancy word, I know. So shoulder impingement, we're going to focus on how rotator cuff, basically how they tear and how they evolve. Tears can stem from either acute trauma, chronic impingement, or a combination of both. However, there's some debate over whether chronic mechanical impingement directly leads to complete rotator cuff tear or whether primary degeneration of the rotator cuff results in tears that cause chronic impingement syndromes. A vital aspect of understanding impingement disorders lies in the anatomy and the interrelationship between the rotator cuff, the long head of the bicep, the subacromial bursa, the AC joint, the acromion, and the humeral head. Among these, the subacromial space plays a key role as a decrease in this space caused by anatomical or pathological changes often leads to large tears. The compromise in the rotator cuff's ability to stabilize the humeral head creates proximal migration, meaning the head of the humerus moves, and when it moves, it chafes and causes irritation, and that causes the impingement. So there are several factors that contribute to shoulder impingement. Let's get into them. First is hypovascularization of the supraspinatus tendon. Then you have mechanical wear. Then you have acute trauma or microtraumas from overuse. Additionally, structural features like the shape and slope of the acromion can predispose people to impingements. The acromion morphology are classified by Biglani into 3 types. Directly influence the susceptibility. So let's talk about it. So according to Biglani, type 1 is a flat undersurface. So now we're talking about the acromion. Type 2 is smooth but a curved undersurface. And type 3 is hooked or beaked undersurface, which most commonly is associated with rotator cuff tears. Now, when we're talking about shoulder impingement, we're going to talk about the NEARS classification. So the NEARS classification talks about the stages of impingement. So stage 1, according to NEARS, is tendon edema and hemorrhage without radiographic evidence and reversible changes. Stage 2 is fibrosis and tendinitis. Still no radiographical findings, but changes are now irreversible. And stage 3 is partial or complex rupture of the rotator cuff accompanied by structural abnormalities like anterior acromial spurs or greater tuberosity excrescence. Let's talk about the evolution of rotator cuff degeneration. Using arthroscopic techniques, researchers have redefined our understanding of this process. These are characterized into 3 stages. I know, 3 different things, 3 different stages. Stay with me. Okay. Type 1 is tendinosis or degeneration of the rotator cuff without visible tears. Type 2 is partial thickness tear affecting either the articular or bursal surface. Type 3 is full thickness tear, rotator cuff tears with varying degrees of structural and functional compromise. Interestingly, though, many rotator cuff tears begin on the articular surface near the tendon's insertion rather than the bursal surface as previously believed. This suggests that intrinsic tendon degeneration rather than purely mechanical impingement might play a primary role in most rotator cuff disorders. Factors like overload and hypovascularity in the critical zone of the supraspinatus tendon may accelerate degeneration. Okay, so moving forward, age, activity, and secondary patterns. Let's talk about it. Most rotator cuff tears are associated with degenerative tendon changes linked to aging, rather than solely mechanical impingement or acromial alterations. Studies have shown that articular surface rotator cuff tears are common even in individuals with normal acromial morphology, suggesting that tendon degeneration is often intrinsic. Bursal tears and full thickness tears, however, correlate more strongly with changes in the coracoacromial ligament and the acromion. Athletes, especially those involved in repetitive overhead activities, may exhibit a combination of degenerative tendonitis and mechanical impingement. In contrast, non-athletes, tendon degeneration leading to tears is frequently of age-related rather than mechanical forces. So some of the key takeaways for this section is in the nearest classifications of impingement, what traditionally described as spur formations might be better understood as part of a broader process of tendon degeneration, progressing to tendopathy and eventually resulting in partial or complete rotator cuff tears. While bursa tears are closely tied to impingement with mechanics, articular side pathologies tend to reflect intrinsic degenerative process. Ultimately, understanding these mechanisms equip clinics to address impingement and rotator cuff pathologies with greater precision, whether it's optimized through rehabilitation strategies or surgical interventions. Okay, let's get into this part now. Chapter 3, common shoulder problems and their conditions. Rotator cuff. Let's do a quick definition. A rotator cuff tear involves damage to one or more of the tendons that make up the rotator cuff. These tendons may become partially or completely torn due to injury or degeneration. Rotator cuff tears affect approximately 4 million people in the US annually, with a prevalence obviously with age. What are some of the causes? Acute injuries, falling on an outstretched arm. So if you're playing sports, whether it's football, basketball, or anything where you're going to potentially fall, baseball, that is possible. Repetitive motion, such as swimming, tennis, or painting, right? You're doing constant motions overhead. Age-related degeneration, reduced blood supply. So as part of aging and as part of degeneration, you're going to reduce your blood supply to the tendons over time. Those tendons, as they become drier, right? So hypovascular, they become drier, they tend to tear. When things have a lot of fluid in them, they are big and thick and full, and they have fluid, they are less likely to tear without an acute injury. But as we age, those tendons dry out. Symptoms typically are pain during shoulder movements, weakness, especially when lifting the arm overhead, difficulty sleeping due to arm discomfort. What are some of the conservative treatments? Physical therapy, obviously, that's your go-to. Anti-inflammatory medications, PRP or regenerative therapies, good stuff. It's coming. And my least favorite is corticosteroid injections. Corticosteroid injections are very good at taking away pain, but what they do on the backside is right. So there's a cause and effect, and there's a cost for all of it. So corticosteroids are very good at taking away pain temporarily, and it does that by slowing down the blood flow, hypovascularization. So when it slows down the blood flow to the area, things dry out. When it dries out, it becomes more sandpaperish, so that smooth articular surfaces become a little bit rougher, and they tend to spike your arthritis over time. 6 months post corticosteroid injections, usually you do have an increase in your arthritis. For some patients, not all patients, but some. Then you also have non-conservative treatment, which are surgical options. Okay, let's get into the types of rotator cuff tears. So you can have a partial tear. Partial tear may involve the articular, bursal surface, or intertendinous lesions. On MRI, partial tears are commonly shown with distinct signal abnormalities. Articular surface tears are more common than bursal tears or intersubstance tears. So you either have a partial tear or you have a full thickness tear. So when they say you have a full thickness tear, what that means is the tear extends through the entire rotator cuff, allowing for direct communications between the subacromial bursa and the glenohumeral joint. The primary sign, tendon deflex, depicted as interruption on the tendon, as the tendon continues. You have joint fluid or granulation tissue seen on MRI. On the MRI, you're also going to see fatty muscle atrophy in chronic tears. Secondary signs, you could have bursal fluid present on MRI. Rotator intravial tears occur in the space between the supraspinatus and the subscapularis tendon, reinforced by ligaments and capsule tissue. It's associated with acute glenohumeral dislocation, typically patients that are over 40, and anterior or multi-directional laxity due to repetitive trauma in young patients less than 35. Subscapularis tendon tears frequently occur alongside tears of the supraspinatus or infraspinatus tendon. They typically characterize their partial tears are, you typically have tendons that are thickening with fiber, and then complete tears, they detach from the lesser tuberosity, and that's all seen on MRI. And then some other abnormalities can be medial dislocation of the bicep tendons. Teres minor tendon tears, uncommon injuries, typically accompany massive tears or associated tears. So typically you'll have a supraspinatus or scapularis tear as a primary large, and then you'll have a teres minor tear with it. So typically it's not going to be a primary tear. Okay, so let's get into shoulder impingement syndromes. Let's get into the definition. I talked about it earlier. What is shoulder impingement? So shoulder impingement syndrome occurs when the rotator cuff tendons or the subacromial bursa becomes pinched underneath the acromion, the bony top of the shoulder blade. This condition can cause pain and restrict motion. So what are some of the mechanical factors? Are repetitive overhead movements commonly seen in athletes and workers using overhead activities. You could have poor posture, which narrows the subacromial space, resulting in impingement. Symptoms typically occur a pain that is worse with movement of the arm overhead, and you have limited ranges of motion and stiffness in the shoulder. Typically, you're going to have conservative treatment, right? You're going to have rest and modification of activities, physical therapy, which are going to focus on improving posture, strength, supporting the tissues, and getting motion back into the joint, and anti-inflammatory. I'm always going to look at PRP to regenerate the joint, because I fully believe in PRP and its abilities to help heal tissues. And then lastly, surgical interventions if needed. Arthroscopic subacromial decompression, ASD, is typically preferred more than acromioplasty. Surgery is generally considered only after 6 months of failed conservative treatment or for chronic outlet impingement. Impingement lesions and MRI findings. In diagnostic shoulder impingement and MRI. So what happens? So if you're looking at an MRI, what you typically see is a lot of changes with degeneration in multiple areas. A lot of times you're going to see what we call fluid in the area. And the biggest thing that you're going to look for is between partial and full thickness tear. So with partial or incomplete tears, you're going to see an increased signal in an area. That means that you're going to have a space between your ligament, where it might not go all the way through, but the full thickness tear, what it shows is a complete separation, like we talked about earlier. So one of the other conditions we can have is posterior superior glenal impingement, typically throwing athletes. These type of impingements is specific to athletes that throw motion. So typically pitches, right? So the glenohumeral is going to get impinged, and the superior labrum, the rotator cuff tendons, and the greater tuberosity, the inferior glenohumeral ligaments are all affected by this condition. So when we talk about shoulder impingement syndrome, it is typically a very common condition, and it's typically caused by repetitive shoulder use and poor biomechanics, leading to pain and tendon degeneration around the rotator cuff. MRI and clinical evaluations are critical for the diagnosis and treatment, ranging from conservative approaches like physical therapy and surgical interventions. Okay, let's get into shoulder arthritis. Shoulder arthritis refers to the progression of degenerative tissue of the cartilage within the shoulder joint, resulting in pain, stiffness, and functional impairment. The most common include osteoarthritis, which is wear and tear due to age, rheumatoid arthritis, which is a systemic inflammatory arthritis caused by the immune system attacking its own joint and tissue. Shoulder arthritis is less common than arthritis in the knee or hip. It is most prevalent in individuals over 60, but can affect younger patients, particularly in cases of RA or post-traumatic arthritis. So it's typically causes are age-related from wear and tear. Genetic factors, there is a family link to arthritis. In rheumatoid arthritis, it's a systemic inflammation of damaged joint and tissue. And other causes can be if you had trauma earlier on and then you didn't heal right. So post-traumatic arthritis, that's how that can come. So a lot of times the condition presents with chronic pain that may persist at rest, difficulty moving your arm, especially rotating it overhead, and then you hear that ever so the crepitus or crackling or grinding sounds during shoulder motion. Typically, the treatments are going to be for this are NSAIDs, right? Non-steroidal anti-inflammatories, physical therapy, right? You're going to go physical therapy is going to be one of your go-tos to improve mobility and strength in your supporting tissues. Heat and ice to keep movements. Again, PRP helps the area, helps with decreasing inflammation, and A3 is a new regen product for arthritis. If you don't know what A3 is, go back and look at some of my previous podcasts, and I did a whole episode on A3. And then lastly, surgical interventions, shoulder replacement surgery, right? So surgery replacement surgery is a big surgery. It's recommended for only the most severe cases where conservative management fails and you have a total shoulder replacement. I always tell patients that surgery is always the last resort, as it is always there. But once you have it, you can't go back. There's no back button. There's no rewind. It's not like a Word document where you can hit the undo button. There's no undo with surgery, right? So once you do it, it's done. And once you do replacement, it is done. So I always tell everybody to really try all your conservative approaches, whether it's physical therapy, occupational therapy, PRP, regen type products to help take care of that before you have a replacement, because a replacement in the shoulder is very extensive. It's not like the hip, right? So if you have hip replacement, it's a much easier joint to rehab and come back from. The shoulder takes a lot longer. Okay, so let's summarize. Shoulder arthritis, though less common than the knee or hip, it significantly impairs the patient's quality of life, especially in those over 60. It can result from age and wear and tear. And symptoms of chronic pain and the grinding, you really got to manage it from getting worse. So the key is get it started, get evaluated, and get it treated. Okay. Now let's talk about frozen shoulder, adhesive capsulitis. Frozen shoulder is the condition characterized by thickening and stiffening of the shoulder joint capsule, leading to pain and severe loss of mobility. It affects approximately 2 to 5% of the general population, most commonly women between 40 and 60. Some of the causes are diabetes how crazy is that? Diabetes is a significant risk factor for frozen shoulder. That is a pretty crazy statement, right? Like, Doc, why are you talking about diabetes? We're talking about frozen shoulder. Yes, diabetes is a significant risk factor. Post-surgical immobilization or injury. So after your surgery, they put you in a sling. Sometimes you're left in that sling too long, and because you left into it too long, that shoulder becomes frozen. So years ago, they used to keep it mobilized a lot longer than they do now. Now they decrease the amount of time they want that shoulder in a sling, and they want some light motion and movement. They want light motion and movement because what they found is, we as people have gotten smarter over time. Well, I hope we get smarter over time. Um, but what we found is that when you keep your arm locked into position over time, your body basically you don't use it, you lose it. That that sentiment is incredibly true for shoulder, especially after shoulder surgery. You have to get it moving. Listen to your doctor, listen to what they say. Be specific with that. So frozen shoulder symptoms typically are progressed through 3 stages. Freezing stage, meaning pain and limited motion. Frozen stage means severe stiffness with less pain. And thawing stage means gradual return of mobility, but typically lasts months to years. Typical treatments, physical therapy for stretching and strengthening, corticosteroids, and obviously, what I'm going to say is obviously the PRP and the regeneration. It is critical if you have frozen shoulder to get the motion in the joint. The more your muscles, ligaments, and tissues stay frozen, the harder and longer it is to recover. The faster you start, the faster you heal. And you do heal. I have people here all heal all the time. Okay, next, let's talk about shoulder dislocations and instability. Shoulder dislocations occur when the humeral head pops out of socket and with repeated incidents can lead to chronic instability. Typically, shoulder dislocations account for 50% of all joint dislocations, the most common in males under 30, typically from traumatic injuries. Loosen ligaments from repetitive dislocations. So the more you dislocate, the more susceptible you are to future dislocations. Symptoms are severe pain and visible deformity during dislocations, chronic feeling of looseness or instability in recurring cases. Treatment, reduction of the dislocation. So maybe you've heard stories or not where somebody came into the ER and they popped the shoulder back into place. Basically, it was dislocated and they put it back into place. It might have, we talked about keeping that shoulder in the middle of the joint, those ligaments, they didn't, and it shifted out. They put it back in. But what happens is those muscles are like rubber bands, and the more they stretch, you keep stretching a rubber band over time, that area of stability decreases, and that's why you have dislocations after dislocation. And once you have one, you're more susceptible to the others because you stretch those ligaments, you stretch that rubber band, and now that area is more susceptible to injuries. So your physical therapy will help strengthen that area up. So that is typically one of the biggest things is to do strengthening program through physical therapy. Lastly, if it keeps happening, then a surgical repair of the torn stretched ligaments would be what you're looking at. So typically, how does shoulders affect you? If you have a shoulder disorder, how does it affect your life? So shoulder problems lead to difficulty performing daily tasks such as dressing, cooking, reaching overhead. You can have problems shaving, combing your hair. with women doing their makeup, right? Anytime you got to put your arm up and you might have pain or you might not be able to do it. You might not be able to comb your hair if you're a woman, especially if you have long hair. You might have sleep problems due to pain. Like if you're a back sleeper, like just laying on your shoulder might cause you pain because of the position it is. Or if you're a side sleeper, laying on that side can cause significant pain. And I know nobody's a face sleeper, right? Sleeping on your belly, that's the worst possible position. Nobody does that. So we don't want to do that. That's bad. Sleep on your back or side. Emotional challenges, including frustration and depression due to physical limitations. So let's recap causes of shoulder injury. So typically trauma, right? Falls, car accidents, sports injuries. Those are the most for trauma. Repetitive motions, um, athletes, painters, anybody who's doing repetitive motion over time. Age-related degenerative conditions like arthritis are typically more common, and systemic conditions like rheumatoid arthritis and thyroid disorders, I mentioned diabetes, are all other areas of causes for shoulder impingement. So let's briefly get into how do you diagnose shoulder problems. So as I always tell you, the best way to diagnose something is have a great physical examination, right? You're gonna have a great history, you're gonna have a great physical where you're going over everything um, that's happening, and that's going to be critical for you for what's going on. And it's important to understand what is going on. So you need to tell the doctor everything, right? So write down all your conditions, write down everything that's happening so your doctor can have the best physical examination. But he's going to give you a great exam. You're going to have range of motion, strength assessment, orthopedic testing, and x-rays to detect arthritis, and you could have MRIs to detect rotator cuff tears. You also could have ultrasound for real-time evaluation of the injuries. You could have blood tests for inflammatory markers like systemic diseases like rheumatoid arthritis. Okay. Brief summary of treatments. Physical therapy is going to be your go-to treatment for rotator cuff injuries. We're going to work with specific exercises to restore ranges of motion and strength of the shoulder. We're going to talk about, then they're going to talk about medications of NSAIDs and my least favorite, corticosteroids to reduce inflammation. And then I like, obviously you all know this now, regeneration with PRP to help heal the tissues. Regenerate. So what, in case you don't know what regeneration is, or with PRP is when we draw blood, we spin the blood. When we do that, your red blood cells go to the bottom, your platelets are on top. Your platelets are what we call liquid gold. That has your proteins, your growth factors, all the goodies of you in them. They take that and they inject it into the different areas, whether it's your joint or muscles, and it helps heal. So it heals tissues from the root down. So it goes down deep into the muscles and ligaments, tissue, heals them from the inside out. That's why it's so cool, because you're healing you. And then you might have, lastly, the non-conservative, which are our surgical options, whether you have arthroscopic surgery to repair tears, remove impingements, or fix instability. Total replacement should be addressed only for the most severe cases where everything else has failed. So, as you can see, the shoulder is an extensive joint with vulnerabilities due to its ability to move, right? Because it is so mobile, it is vulnerable to different injuries. And that's what makes it so hard necessarily to diagnose and treat, but that's what takes time to heal. So if you have found this information helpful, please don't forget to subscribe to the podcast, share it with someone who may benefit, and as I always say, The opinions you heard here are my opinions alone. If you have a problem, please see your own physician. Let them diagnose you. Let them treat you the right way. What I went over today is not meant to be a treatment diagnosis or anything of the sort. It is just my opinion alone. With that said, if you have a problem, don't let it linger. Take care of it now. The longer things linger, the old notion of, it'll eventually go away, it'll go away, it'll go away. Then before you know it, you're 6 months, 8 months, 1 year, 2 years in, and like, oh, it hasn't gone away. Now it's gotten worse. It's harder to treat conditions as they get worse. It's easier to treat them in the beginning, right? So pain is not the first indication of a problem. Pain is like in the 70th percent part of when it's a problem, right? It's been building over time. Now you realize that that's pain. That's like 70%. So you already at 70% of an injury because pain as when is the first time it started, but it's been building and building and building and building. Obviously, if it's acute, that's a different story. But if it's not acute, then it's building over time. So treat that first notion, get it taken care of, go see a professional. Because at the end of the day, your health matters, and we only got one of them. So take advantage of it, take care of yourself, be well. I'm Dr. Chillemi. Till next time, be well, be safely, and your health matters.